Now we have Dr. Friedman, who is also the co-director of the MGH Center of Excellence, and I'm excited to hear her presentation. She's fabulous. Thank you.
Hi. She's so fabulous. She can't figure out the slideshow thing. Hold on. Okay. So first of all, thank you so much all for being here. This has kind of been an extremely exciting thing to start building the center. And the most exciting thing about it has been working with the various people in the field. I've met some incredible clinicians and researchers, and I've had such wonderful mentors. A lot of you might have seen them either in clinic or heard them speak, and I'm so grateful that they've brought me to such a great community of the CMTA and all of you. And my colleagues at Mass General are wonderful people, and I'm excited for you to get to know them if you haven't already. So I'm going to talk about a few things leading up to this idea of what we're really facing as the main challenges in doing research in CMT and finding treatments, which I think is interesting as the physiology and anatomy is. Most of you are probably wondering, when, if we're going to be able to make the disease go away and not be interested in it anymore. So I'm going to start just talking a little bit about how we characterize the neuropathy. Some of this will echo what Dr. Chad so eloquently said just now and build on it. I'm going to talk about how we approach genetic testing, why we do genetic testing, should we do genetic testing, and in the really dramatically and rapidly changing climate of genetic technology, how we adjust our current thinking and our future thinking. We'll mention some treatment trials, and then importantly, how do we measure CMT over time? How do we know potential treatments work? What do we need to do to make that better? So just briefly, because you've heard a lot about this just now, hereditary neuropathy, classically, we think about it as a distal weakness and numbness problem, a stocking glove sensory loss, as Dr. Chad just mentioned, with foot deformities, which really distinguishes these conditions for us from the many, many other causes of peripheral neuropathy, such as drug-induced or immune responded neuropathy. And then these diseases are slow, and they move slowly over many years and don't tend to affect mortality. Again, that distinguishes them from some of the neuromuscular diseases we see in clinic. So while that's the classic vision of CMT, that length-dependent sensory motor loss, we know that really this is a huge spectrum of disease and a very heterogeneous set of diseases. And you see that here. So the umbrella term of hereditary neuropathy or Charcot-Marie-Tooth disease really encompasses a varied number of diseases that can look very, very different. So the most common here is the hereditary motor and sensory form. However, we have the pure sensory forms where strength is completely intact. We have on the other side of that spectrum, the pure motor forms where people have weakness but have never experienced numbness or tingling or any sensory symptoms at all. And then there's a distinct category, hereditary neuropathy with liability to pressure palsy, which some of you may have heard of or maybe have, which is in contrast to the progressive slow symptoms, a relapsing, remitting episodic disease where patients have weakness that comes and goes and numbness that comes and goes. So it behaves very differently. And again, this is the most common inherited neurologic disease, highly underestimated at a prevalence of 1 over 2,500 because we know patients don't come to medical attention or don't get the right diagnosis. So how do we characterize the neuropathy? So you heard about the history, and the history really has to come from you in a very detailed way, targeting especially childhood and early years. And what happens is I think many patients perceive their problems, they'll come to clinic, they say it started in adolescence, or it started when I was, in my 30s. And then when you really sit down and carefully talk about the early years, it turns out that actually it's probably been with them most of their life. Questions like, did you twist your ankles more than other kids? Did you run races slower than other kids? Did you have to have special shoes? And all of a sudden, things that just seem normal, and maybe other people in the family had the same difficulties, so it was just considered, it runs in the family, turns out to actually be the beginning of CMT. We do a careful examination looking for the pattern of weakness of the muscles, the pattern of sensory loss, any clues or associated features that might point us to a specific genetic diagnosis. But the gold standard after all that to really make the diagnosis is genetic testing. So once we look for the genes involved in CMT and find a mutation in a gene that we know causes it, as long as it fits the clinical disease we're seeing on our examination and hearing from you by history, we've made our diagnosis. And so that really is when we can say with confidence, you have CMT of this type. So let's go back again a little bit in history. So P.K. Thomas and Anita Harding in London were the first to really think about how we're going to define these neuropathies and separate them into categories. And to review a little bit what you just heard, we think about whether the disease is sensory motor or both sensory and motor, inheritance pattern, how is it passed on, and then is it targeting the axon or the myelin? So is the conduction of electric current through the nerve slowed or is it normal? And they really divided it into these axonal and demyelinating forms for the first time. So I'm going to go through this in a little more detail because I find that with my patients in clinic, they like to hear this more than once, and that it can be a little bit hard to wrap your mind around. So for some of you, I know this is review and I apologize, but I think it's worth talking about. So an autosomal dominantly inherited disease is one where we all have 2 copies of every gene, 1 copy is abnormal, and that's enough to have the disease. So like the father here in blue, he has 1 abnormal blue copy and he has CMT. When he has a child, each time he has a child, there's a 50% chance that he'll pass on that blue gene versus the normal gene. So there's a 50% chance that the child will be affected. And you see that there's 2 children here who are affected and 2 that aren't. But it could have been that none of them were affected or that all of them were affected. It's a 50-50 chance with each child, independently of what's already happened. Now, recessive inheritance is different. So here, you again have 2 copies of every gene, but you need 2 copies that are mutated to have the disease. And if you only have 1 copy that's abnormal, you are a carrier. You don't necessarily manifest symptoms. So these 2 parents both are carrying the gene, and to have the disease, they have to pass on their mutated gene, both of them, to their child. So they can each pass it down 50% of the time, but for them to both pass it down, it's 25%. And so a quarter chance that their child will have both copies affected. And that's the child you see in blue. The other children, so one girl here got 2 normal copies, so she has nothing. And then the other children got 1 abnormal copy, and they're carriers who then, if they had children with another carrier, could potentially pass the disease down. So you see how it's harder to inherit a recessive disease. It's less likely. So when we hear about families where only 1 person is affected, for example, that's something we wonder about. Could it be autosomal recessive? That's much more common in regions where there's a higher rate of continuity, meaning that people marry within families, even if they're somewhat distant relatives. But it's something to be considering. And then there's X-linked inheritance. So here, the problem mutation is on the X chromosome. And of course, women have 2 X chromosomes, and men have 1 X and 1 Y. So this man here has an X chromosome with the mutation. If he has a son, he's going to give that son his Y chromosome, not his X. So there's no way for him to pass the disease on to his son. So that's an important point. So when we're taking the history, if we hear that there's a history of someone's grandfather having passed the disease down to their father, we know it's not X-linked. And that's important. It helps us throw out, a few diagnoses right off the bat. So what's happening with the classification now? I told you what P.K. Thomas and Anita Harding initially decided on, but now we have more than 80 genes that we know to be causative, and those genes are being added to all the time. They're growing. How are we going to incorporate that? So I'll give you the big categories here. So CMT1 is the dominantly inherited demyelinating neuropathies. CMT2 are the dominantly inherited axonal neuropathies. CMT4 traditionally thought of as all the autosomal recessive neuropathies. And then there's CMTX, X-linked CMT, and HNPP, hereditary neuropathy with liability to pressure palsy. And I'm not going to go in detail through these genes, but what I will say is that 90% of the time when we can get a diagnosis in a patient and tell them what the gene is, it's going to be one of 4 genes. So most of the diagnosable CMT remains in 4 common genes. And once we've tested for those 4 and we still don't have the answer, the likelihood that we find one easily drops significantly. And I'm sure many of you have experienced that. And so by virtue of that, we're only getting a diagnosis in up to 67% patients, even in very competent neuromuscular centers. So there's definitely work to be done. Just a word on biological mechanisms. We are not going to go in detail through this figure. What this is telling you is that as we've learned more about the biology, we see that these genetic diseases that cause CMT, they have common molecular pathways involved. So some of them, for example, will affect how the cells talk to other cells. Some will affect how the cell transports molecules up and down the cell. Maybe there's one that affects how proteins are made. Maybe those molecular pathways are a more important and meaningful way to characterize these diseases, because that's what's going to lend itself to creating therapies. So maybe we're thinking in the future of abandoning a little bit some of the historic classifications in the interest of actually classifying patients according to their mutation and what it does at a molecular level. Okay, so back to you, away from molecular things now. So do we need to do genetic testing? You know, does it matter? I think many of you probably experienced this feeling of being told, well, you have CMT most likely. It might even be CMT1A, for example, from what I can tell, but there's no therapy, and so expensive genetic testing may not be worth it. Maybe we'll just, not do it. And that was the mainstay kind of approach for a long time, but clearly has shifted very recently with the advent of genetic testing and the technology. And the reason is that it does make a difference. So we can offer genetic counseling. Patients have a better understanding of what to expect when they have children, but also what to expect for their own symptom progression, because different CMT types behave a little bit differently. We can preempt symptoms associated with a specific genetic diagnosis. So if we know that there's something that causes hearing loss or causes visual trouble, we can be looking for those things. And of course, then there's clinical trials, for which most of the time we would like the diagnosis to be defined. So how do we do genetic testing? So it used to be that we had, 1 or 2, maybe 4 genes, and we would test one gene that we thought was the most likely, and then if it wasn't that, we would move on to the next gene, and it would take a long time, and patients, could get frustrated. Sometimes we still do that in certain cases, but more and more, the field has really moved to doing panels of genes at once. So all the genes that look like they could fit that clinical presentation, we can now very rapidly and much less expensively do the testing. So that's kind of what most clinicians will tend to do. What about exome sequencing? So now it's possible to sequence all of the coding DNA very rapidly. So should we just do that on everybody? Should people just walk through the door, get an exam, and get exome sequencing? And the answer is it's complicated. It's not that straightforward. And why is that? Well, first of all, the more genetic material you look at once, the more you lose the thoroughness with which you're evaluating that genetic material. So you may miss variants, you may miss the mutation, and so your false negative results go up. Also, we get back a lot of variants that are not clearly pathogenic that we then don't quite know what to do with. So all of us have up to 400 variants in our genetic material just walking around. So if you test all of the exome sequences, you're going to come back with a lot of undefined abnormalities, and you have to then try to figure out what to do with them. And, that's frustrating for patients too. We've done all this testing, and we have these 6 variants, and maybe one of them is causative, but we're not sure. And, there are ways to sort this out. You can test other family members. You can look at the molecular level of what that mutation is doing and see if it likely is causative, but it's a big undertaking. So the answer is there are certainly advantages to exome sequencing. We can find new genes that way. We can expand what a specific gene can do, right? So we would have maybe never tested for this particular gene in this patient, but it came back as abnormal with exome sequencing, and it did in this other family. And now we know that maybe actually there's a different clinical presentation that gene can cause. So that's another advantage. And then, of course, the more understanding we have of the biology, the more likely we are to find therapies. But I would say at this point, it's a case-by-case basis. We definitely try to exhaust the more limited testing that we do before going to exome sequencing. But that's likely going to continue to change. It's a moving target. So now we're just going to go through a case, and I want to tell you a little bit about the thought process that we have as we lead up to genetic testing, and this will probably sound familiar to many of you. So I'm going to tell you she has CMT1A. She's an 18-year-old woman, but we'll see how we get there together. So she comes into clinic, and she says that she walked on time as a kid, but she was always clumsy running. She was always last in races, and she had high-arched feet. So suggestive. And in her adolescent years, she's starting to turn more on her ankles. She's going to the ER with sprains. So now it's becoming more of a problem and more symptomatic. She has a lot of pain in her back and her knees, and she has some trouble writing long exams because her hand is a little bit weak and she's cramping. So what's the first thing we're going to think about as a guide to our genetic testing? Well, it's her clinical exam. And so she on exam is unsteady. She has foot drop. She can't stand on her heels, and she has wasting and weakness of her hands and her ankles and her feet, and clear weakness in the fingers. and no reflexes. She has reduced sensation when we use the pin and a little cotton and can't feel much below her knees. And so she has sensory and motor, what looks like neuropathy, that started very young with foot deformities. So we're thinking she may have CMT. So then what do we look at? Well, now we look at her pattern of inheritance. So what's her family history? That's always going to be very high on our list when we're talking to you. And here it is. And for those of you who aren't used to looking at these, so the circles are women and the squares are men. And if it's shaded in, that means they're affected. And she here is down here with the arrow. And her sister has the disease and her father and her grandfather. Okay, so is this a recessive pattern? What do you guys think? There's murmurs. So no, because there's many people affected, right? So we said that makes that much less likely. So is it an X-linked pattern? I'm hearing mixed responses, but I'm going to go with the people who said no. And why no? Because we see that a grandfather has passed the disease on to the father, and he would have passed his Y and not his X chromosome, right? So this is not X-linked. So this is likely a dominant pattern of inheritance. You guys are all going to be ready to see patients in a couple minutes. So now we're going to do electrical testing, and I'll just tell you without going into it too much that her conduction velocities were very slow, and that tells us it's demyelinating. Okay, so she has a sensory motor demyelinating polyneuropathy that started in childhood. Now we look to what's common. So what's the most common cause of that type of neuropathy? Well, that's CMT1A, hands down the most common cause. And we may just start by testing for that because of how common it is. And that's what she has. She has CMT1A. So let's talk for a minute about CMT1A. So this is a duplication in the PMP22 gene. You have an extra copy. We know that a deletion, so a loss of PMP22, results in hereditary neuropathy with pressure palsy. We don't exactly know why, but we know that PMP22 is a very important protein for nerve health because when you disrupt it any which way, you get neuropathy. So again, very common, and clearly the temptation is to reduce the expression of PMP22 since you have a duplication. You have too much of it, and that has been a huge therapeutic target in CMT. And down here in the photograph, you see those onion bulbs that Dr. Chad was just talking about. So let's just shift right from that to treatment trials. And here we go. How are we going to try to treat PMP22 duplications? Well, we want to lower the level of PMP22. Now, why do you see Smarties? Okay, you see Smarties because my mentor in London would tell all her patients, if we're going to have a cure or a treatment for CMT1A, it's going to have the side effect profile of Smarties, and that's what they eat in London. I tried this with a patient when I came back to the States after that training, and they had no idea what I'm talking about. So M&Ms, it's going to have the safety profile of M&Ms, right? Because we can't justify giving someone with a slowly progressive, mild, comparatively to something like ALS, disease a toxic medicine with side effects, right? It has to basically be side effect free. And luckily, early on, one of the agents identified that actually does reduce PMP22 expression is vitamin C, which we know is safe. And it worked on a molecular level, and it made the animal model in mice of neuropathy with CMT1A improve. So it was a very hopeful story. There were 3 large clinical trials. None of them showed any response, as many of you probably know, in patients with CMT, or at least the response that we could measure. And so this trial, the reason I showed to you, even though it was negative, is because it had a really important role in letting us redefine how we measure progression in CMT, because even the untreated patients in this trial seemed to get a little better according to the scale that we were using at the time, which didn't make a lot of sense. And here's that scale. This is sort of the gold standard bedside test we do to quantify the severity of CMT. It's called the CMT neuropathy score. We ask you some questions, and you'll see us do this in clinic if you haven't already. Then we examine you, and then we do a couple electrophysiologic tests, and we put it all together into the score. But it wasn't detecting change well enough. So I'm not going to get into this very much because you're going to hear talk about it later. But this fantastic STAR strategy, which is targeting treatment and cure of CMT through bringing people together, like expert clinicians, whether they're in biotech or academia, to kind of expedite the process of treatment discovery and developing assays that can look at large numbers of possible treatments, possible agents to reduce the PMP22 just like vitamin C did, except hopefully this time more effectively. So this is an aim to develop rational therapies, but we have to have a way to measure whether they're working. And so the obstacles to that are, one, we don't have enough information about how the disease progresses over time in the untreated state. So that's the natural history of the disease. We don't have reliable enough outcome measures right now, biomarkers, to say, is the disease worse than it was a year ago even, because the disease is so slow. And then there's the issue that one gene can cause two different clinical presentations. So how are you going to do a trial with patients who have different symptoms to begin with? How are you going to measure? Well, you almost have to measure their individual problem and see how it's changing over time. And so that brings me to sort of the end of the talk, which is the INC Natural History Study. This is the Inherited Neuropathy Consortium, which of course is where the Centers of Excellence come together to do research. And there's been an effort to collect patients, natural history study patients, to put the information we see on their clinical examinations, electrophysiology, into a huge database that houses many more patients with CMT than any individual center could collect. And that we have 16 participating sites. That's both within the US and abroad, so places like London and Australia. And they've been enrolling since 2009, and it's been really great to get involved with that here at MGH. And I am showing you a very limited slice of the total patients who I've recently analyzed because they had absolutely everything that I needed them to have readily available to give some preliminary results at the Peripheral Nerve Society. And there's almost 3,000 patients I was able to look at. Returning at 1 year and 2 years, you see the numbers dwindle, and we've worked hard to get those numbers up since. And within that population of patients, I want you to see that we've really aimed to represent all subtypes of CMT. So not just the common ones, but really all of them. And this pie chart kind of shows you that. We have CMT1 and 2 and recessive and dominant, and we have all different degrees of, demyelinating intermediate axonal forms, and we're trying to certainly continue that. So the more patients with rare forms we see, the better. And you see also importantly that the age range of the patients is really wide, and that's important too. So if we have a treatment, we're going to be giving it to patients of all different ages, including infants. In fact, you'd want to give it to infants. You want to prevent progression early on. So we need to know how it behaves. Maybe it changes over time as people enter adulthood. So I'll show you one thing that the study has already allowed us to do, which is it's allowed us to take this score that we were using for the vitamin C trial, modify it through various very thoughtful approaches, statistical approaches, and try to make it so it brings out the progression in a more sensitive way. And I was able to look at the patients that we've seen over the past few years of the natural history study and say, well, is it better? Is it working? And the answer seems to be that it is. So I'm not going to bore you, but if you look at the bottom of this graph, you can see that these are CMT1A patients that we're seeing at 1 year and comparing that to when they entered the trial, and then 2 years comparing to when they entered the trial. And we don't see much change. It's a flat line. Whereas at the right lower hand corner, we're using the new modified scale, and you see that change is now brought up. So we see a little bit of change at 1 year, a little more change at 2 years, and that's what we want to see. But that's not enough. So looking to the future, how are we going to measure CMT? Well, this may be part of it. We need to continue to refine the clinical instruments we use, not just the CMT neuropathy score for adults, but there's one for children, which, kids can't cooperate the way adults can. So it's more, can you put pegs in holes? Can you run around? Everything gets timed and documented. And there's actually an infant score in development. You can imagine that infants really don't cooperate. So you really need to get them measured in some way where they have nothing to do with it. And Orani, who's worked with Michael Shai, has done a great job creating this. And you have no idea how much work goes into creating one of these instruments, and now it's being tested in clinics. But what else do we need? We need objective biomarkers. And so the London group has worked hard on MRI, and it turns out that the size of muscles on MRI actually is quite sensitive to change in CMT over time. Why is that? Well, as Dr. Chad said, the health of the nerve is very much reflected in the health of the muscle. And nerves are not easy to image on MRI, but muscles are. And so perhaps that's going to become a mainstay way to compare how people are doing over time. Skin biopsy has sort of started to replace nerve biopsy because that's quite invasive, so we can look at nerve endings in skin and start to analyze those. And then there's functional tests, how fast can a patient do something? Things where a stopwatch tells us really, are they better than last year rather than our bedside exam. And the most important one for this conference is patient-centered outcome measures. There's been a lot of push to start paying more attention to what patients think is important about progression, what you notice as symptoms that weren't there a year ago, and learning from you and incorporating that into the way that we measure disease in clinical trials. Because at the end of the day, a treatment has to reflect you feeling better, not some objective biomarker that we've created. So most of us, I think, see the field moving in a direction where there's a conglomerate score that includes the clinicians, bedside instruments, biomarkers, and patient-centered outcomes, sort of all involved in measuring disease progression. So in conclusion, genetic testing in CMT is very complex. It's becoming more complex with the advent of next-generation sequencing. We're almost getting ahead of ourselves, like we can get more information than we can analyze, and a lot of computer bioinformatic type involvement has started to make that easier. It is helpful to define a genetic diagnosis when we can for counseling and for research. We need better natural history studies and outcome measures, and we need all of you to come and participate in these natural history studies and give us your feedback about what you think is important in the disease. So with that, I'm going to close and just thank my mentors in the Hereditary Neuropathy Consortium who trained me, my colleagues at Mass General who've really been amazing in trying to build this up in the last year and a half, and the CMTIA, of course, for letting us talk to you guys today and bringing us all together. Thank you.
Thank you very much, Dr. Friedman. Thank you.